there. Welcome.
Thank you. It's good to be here with you, and I'm really appreciative of this invitation by DJ and working with me with our family vacation schedule and letting me come on. I want to speak about a topic that I'm particularly passionate about, and that is atrial fibrillation and dementia. And really pose the question, can dementia be prevented in patients with atrial fibrillation? And this is something that's certainly, as I'm dealing with my mom who has early dementia and we're going through some of these things, dementia is really one of the most cruel things that people can develop. And as we think about atrial fibrillation, too often with some of these rate versus rhythm trials that have come on, what has almost been translated to the general practitioner is atrial fibrillation doesn't matter. Put them on warfarin or one of the novel anticoagulants and forget about it. There's something more there, and there's a way that we can intervene because these patients are at significant risk of dementia. And so with that, I'll jump right in. First, start with a case. This is a 67-year-old man, actually my former scoutmaster. If any of you have treated people from your past, it's certainly a very unique situation, who presented to me after he had developed paroxysmal atrial fibrillation late in 2012. His disease rapidly progressed to persistent AF in 2013. Despite high doses of flecainide, multiple cardioversions, he could not even hold rhythm. So a very rapid progression of his AF. He did have some dyspnea and fatigue with his AF. Otherwise, he was in good health, lone AF, exercises daily, was a little bit overweight. So the next step is, what can we do to minimize his long-term risk of dementia? I'm just going to see what you're thinking here. And we'll quickly run through the choices. A, you could try a different antiarrhythmic. B, try one of the new novel anticoagulants. C, AF ablation. D, none of the above, or you don't know. How many A's? Okay, B, C, a few there. D. All right, so it looks like C's and D's are the most popular. Well, let's hold that as we move through with this. Now, one of the things in trying to tease out atrial fibrillation and dementia is the same risk factors for atrial fibrillation are the same risk factors for dementia. And so by treating the heart, we can also treat the brain. Age is an important risk factor for both AF and dementia. Obesity. With the obesity epidemic, we are seeing increased episodes of atrial fibrillation as well as dementia. Diabetes, hypertension, smoking, alcohol intake, systemic inflammation, and then there are also genetic factors that are involved as well. This was a study that we published, our group published in 2010, and actually it was the #1 cited arrhythmia article in 2010 in the Heart Rhythm. And this was from a large database that we looked at Intermountain Healthcare, where for the first time we were able to pretty clearly demonstrate that atrial fibrillation is independently associated with senile, vascular, and Alzheimer's dementia. When we presented this, this was picked up by thousands of news media around the world. We even picked up in the Tehran Times. So this is an important world event. As we really, dementia and atrial fibrillation are huge burdens as societies become progressively more westernized. And so when we looked at it, and this is really a summary of the data right here on this slide, we had 37,000 patients with 5 years of follow-up. All of these patients had an MRI, brain imaging, as well as a neurologist-confirmed diagnosis. Now, one thing that we saw that was particularly interesting is that if patients had both dementia and atrial fibrillation, that we saw a particularly rapid decline in their cognitive function as well as their survival. But if you look at this, whether it's nonspecific, Alzheimer's dementia, senile or vascular dementia, you see a more than doubling of the risk with atrial fibrillation. Now, what was really quite scary with this is we talked about that age is often a co-founder. We did not see that here. When we looked at the risk of Alzheimer's disease, you can see that the primary risk of this was in our younger group with atrial fibrillation, the under age 70. If patients develop atrial fibrillation, we found, particularly in the younger group, that they were almost 3 times more likely to develop the Alzheimer's form of dementia. So clearly, this is something that is important, and it is a cause of early dementia. Atrial fibrillation is something that we really need to pay attention to. When we looked at mortality risk, dividing it out by nonspecific Alzheimer's, senile or vascular dementia, the same thing was seen as well. Increased mortality in all of these with atrial fibrillation. Well, after this has come out, there have been a number of other studies, and how does our study stack up? You can see there have been a number of studies all published in the same area, and from this meta-analysis, you can see that all of the studies seem to indicate the same thing, that dementia is significantly increased with atrial fibrillation. So how do we sort this out? How does a patient go from atrial fibrillation to dementia? Are we even thinking about this? And this is something that I'm going to challenge you, is we need to think beyond the now. We need to look at our patient. What is their long-term future? What are the mechanisms? What interventions can we make? There are a number of potential mechanisms. It could be comorbid disease progression. For example, their diabetes or poorly controlled hypertension. It could be macro or micro thromboembolism. There could be genetic factors. There could be intracranial bleeds or also microbleeds. And we're going to talk a little bit about microbleeds because this is something that the cardiology audience really, for the most part, is unaware of. Systemic inflammation. It may also be a function of cerebral blood flow. So when we look at the spectrum of thromboembolism, there's a wide spectrum. Certainly we can see from our images here the thrombus in the left atrial appendage. We can see the poor flow from the appendage, and you can have the acute macroembolism, or perhaps what might even be more important in the developing dementia from atrial fibrillation, it could be microembolism or chronic cerebral ischemia over time with one of these more chronic disease manifestations. This is a collection of all the major trials with warfarin, looking at the risk of intracranial bleeding with warfarin. This is something that we are all very familiar with. And if you look at these trials, you can see that the range is anywhere from about 0.5% up to about 2% per year risk of intracranial hemorrhage. This is something that is certainly very feared, certainly is a risk factor for dementia. Fortunately, with the newer anticoagulants, this risk seems to be about half of what we've seen with warfarin. This is something we're all familiar with. What I want to talk a little bit about now are the microbleeds. And this is something that is very well discussed in the neurology literature, but really has been absent in the cardiology literature. With anticoagulants, you can get these microbleeds. And I have some MRI images. They show us these little tiny black dots. And they can be deep within the brain or at the cortex level. They can be really at any place. These microbleeds have been linked with long-term development of dementia. And these microbleeds are actually very common. These are a number of studies, and this is from a nice review in the neurology literature. You can see that here in the red with the warfarin microbleeds can range anywhere from 1 to 10% of the patients on warfarin develop these microbleeds. This is something that is real, and it's actually really quite interesting. As I talk with my neurology colleagues, they're very fearful of anticoagulants in atrial fibrillation because of some of these potential microbleeds and other issues and risk of dementia. On the other hand, the cardiologists seem to be very aggressive about anticoagulation. And so where really does the risk-benefit balance lie? We don't know. But this is something that I would like at least people to be aware of, is that microbleeds are an important cause of dementia and are significantly increased with anticoagulation therapy. Hopefully with the newer novel anticoagulants, this will not be as much of a risk. Data is not yet out on the risk of microbleeding from the novel anticoagulants. Well, what could be other causes of dementia with atrial fibrillation? And these are some nice hemodynamic tracings. You can see in the upper left patient in sinus rhythm. When you look at the femoral arterial line, nice uniform pulsativity. However, with atrial fibrillation, as we are all familiar with, you get rapid fluctuations in the RR intervals, the blood pressure. And then when sinus rhythm is restored, this is normalized. Could these alterations in cerebral blood flow also play a role in the subsequent development of dementia in a brain that potentially is at risk of developing dementia? And this was a nice study that was published last year where they looked at cerebral blood flow, regional cerebral blood flow in patients without atrial fibrillation or with atrial fibrillation. And you can see in the yellow and the green with no AF versus the blue and the gray with AF that when it didn't matter at what part of the brain they looked at, with atrial fibrillation, they did see a significant drop in cerebral micro blood flow. Interestingly, with AV node ablation and pacemaker implantation, this normalized. And it certainly raises the question of, could these fluctuations in the RR interval, blood pressure changes, and the way it affects cerebral blood flow also potentially be a mechanism of long-term dementia in potentially a brain at risk of developing this? Inflammation is something that has been well described. This goes way back from Mina Chung a number of years ago, and there have been a number of other studies showing that inflammation and atrial fibrillation go hand in hand, that this is really one of the many chronic diseases that is especially becoming more prevalent in the West. And as you develop from control, no AF, to paroxysmal to persistent, you will see an increasing level of C-reactive protein. Interestingly, the same graph could also be shown when you look at dementia or Alzheimer's disease. Patients with dementia tend to have higher levels of C-reactive protein as well. Could there be some common link of systemic inflammation, whether it's our lifestyle, et cetera, that may be also accounting for these increasing increasing levels of rates that we are seeing with both dementia and atrial fibrillation? So what can we do to prevent dementia? We know that mental stimulation is important, keeping the brain active throughout the life. We know that exercise is very important. We know that there have been a number of studies showing that certain antioxidants with a more plant-based diet, less of the processed foods, meats, and some of these others, may be associated with decreasing risk of long-term dementia. Antioxidants, omega-3s, social interaction seems to be very important in preventing this. Rejuvenating sleep and stress reduction. And so I commend DJ and his group with the atrial fibrillation run and yoga, working on exercise and stress reduction, that these will also help in managing AF and may also help in preventing long-term dementia. What can we do? Are there any medical interventions to prevent dementia? When we look at antihypertensives, there's a lack of randomized clinical trials, and is there a benefit once cognitive decline has already happened? Certainly we know that keeping the blood pressure in check over a lifetime can reduce the risk of dementia. Cholinesterase inhibitors, is there possibly a delay in dementia progression? Statins, which we know are also powerful anti-inflammatory agents as well. We've seen mixed results. Hormonal therapy, haven't seen a benefit. Non-steroidal anti-inflammatory drugs, mixed results. Supplements, mixed results. So as most of us are treating heart rhythm abnormalities, as we know that atrial fibrillation is a very potent risk factor for dementia, are there things that we can do on the heart rhythm side that can also help this? And this was a study that we published in JCE in 2011, looking at a large database of if we can eliminate atrial fibrillation, and in most of these patients we were able to get them off of their anticoagulants, can we potentially change the long-term risk of dementia? And once again, when we published this, as dementia and AF are such important topics, this received worldwide press as this showed for the first time that potentially treating the heart is also treating the brain. And in this study design, we had nearly 38,000 patients from Intermountain Healthcare. we had 4,212 consecutive AF patients. Basically, every patient at our institution who had ever had an AF ablation procedure was included in this analysis. We had two control groups. Each control group had approximately 17,000 patients. One control group was age and gender matched with no history of AF. The other group was age and gender matched with atrial fibrillation, 3 years follow-up, mean age of 65. And you'll certainly see that when you do this type of research, you get a little bit of a mixed bag on demographics. But if you look at the AF ablation group, which is the third column, you'll see that these patients, they were less likely to have diabetes. However, they were much more likely to have hypertension, much more likely to have heart failure, much more likely to have a history of significant cardiac valvular abnormalities. Well, the success rate off drug, no antiarrhythmics, was 64% at 3 years in this group. 28% required a redo ablation. You can see the complications listed below here. Fascinatingly, when we looked at mortality, you'll see three graphs here, the three groups. The group in black is AF with ablation, blue is no AF, green is AF without ablation. We saw a significant survival advantage in those patients who had undergone AF ablation. Similarly, with stroke risk, we saw the same curve, that patients who had had an AF ablation, and most of these patients were AF-free, either without drug or with drug, but most of them were AF-free, that their long-term risk of stroke was almost as if they had never developed AF in the first place. However, those that were medically managed continue to have a high stroke rate through the course of the study. When we looked at the incidence of dementia, once again, similar trends. Those patients with ablation whose AF had been eliminated either with ablation or ablation plus medical therapy, is that we saw that their incidence of dementia was as if they had not developed atrial fibrillation in the first place. When we looked at the long-term risk of dementia, comparing in the yellow ablation versus no AF, or in the white no ablation versus no AF, you'll see that in patients who had the ablation, that we had the AF eliminated, that they had a decreased risk of all forms of dementia. Conversely, those who had ongoing AF, that there was an increased risk of all forms of dementia. Now, I want to just take a step here. There have been a number of studies that have come out recently looking at the risk of silent strokes with AF ablation. And interestingly, in the last issue of JACC, there was a nice article on the risk of silent strokes in patients in any patient with AF. And so silent strokes, whether you have an ablation or you don't have an ablation, is something that is important. And this is something that has been reported in the last few years. The incidence is not yet clear. It is not yet clear on risk factors. Can this potentially be avoided with more aggressive anticoagulation, keeping sheaths out of the left atrium, the selection of equipment, minimizing procedure times? This was also in the last issue of JACC. That is something that needs to be brought up as well if we're going to talk about the issue of dementia and atrial fibrillation, is subtle post-procedural cognitive dysfunction after AF ablation. And I don't know yet what to make out of this. This is the first large study looking at this, where they saw that there was a 13% risk if the patient had paroxysmal AF, 20% of persistent AF at 90 days with AF ablation. Interestingly, some of the same things have been seen in the cardiac surgery literature as well. How do we try to explain it? How do we try to reconcile it? Is our data from a large population of nearly 40,000 patients, how do we reconcile that with some of the other data that have been presented from small studies? Interestingly, at our center, we have looked at trying to look for these silent strokes after AF ablation. And whether we are just not doing it right or something is different with our technique, we are not seeing it. Interestingly, we have seen it in patients that have been treated at other institutions that then present at one of our Intermountain facilities with a cerebral event. Also, we see a very, very low incidence of stroke following ablation, and this has been seen in other large studies. For example, from Andrea Natali's group and others, they've seen a low risk of stroke long term. Our procedure times tend to be much shorter, about half the length that is typically reported in some of these studies reporting cerebral events after AF ablation. We do not use sheaths in the left atrium. Once the catheter is placed in the left atrium, we remove the sheath. Could the sheath be an important cause of microembolism that could account for some of these? We treat our patients fully anticoagulated ahead of time, full anticoagulation before we ever enter the left atrium. Could that also be a potentially safe strategy? Also, could it be in how we treat our patients? We have a very holistic response. Daily physical activity is reviewed with the patient on every visit and is strongly encouraged. We encourage a more plant-based diet with fish. Everyone in our clinic is screened for sleep apnea. We have aggressive blood pressure control. Could it be these other factors that we're treating as well that could account for this improved neurological outcome in our AF patients? So, not to leave you hanging, what happened to my Scoutmaster that we presented at the beginning? Well, he had his first AF ablation in May of 2013. Unfortunately, he continued to have ongoing AF. It was not effective. He had a redo ablation a couple of weeks ago. He's still maintaining sinus rhythm, doing well, has not gone out of rhythm, so we're keeping our fingers crossed. He's on an amiodarone and apixaban at this time, and hopefully we can get him cured. If you have any questions afterwards or want to grab me, email me, contact me via social media, welcome that. Thank you for your attention.